We have an action-packed agenda today. I'm so excited to welcome you all to our kickoff of the fall season of Grand Rounds. What will be more appropriate than starting with the Chair of Medicine Scholar Award recipients? I personally can't wait to hear their presentations. Again, full agenda, so I'm gonna not waste any more time and hand it off to Dr. Lyles.
Welcome everyone to the inaugural presentation in the Medicine Grand Rounds series for 2020-2021. And today we're having talks from our Chair of Medicine Scholar Award recipients for 2020. The Chair of Medicine Scholars Awards were established in 2013. They were designed to assist promising physician scientists in their transition from the senior fellow acting instructor status to assistant professor. Also, it's the so-called K to R transition. And this is really to assist those individuals as they then transition from mentored awards to PIs. And today we have three talks from our three recipients for 2020. Each year, the Department of Medicine solicits nominees from the divisions, and the division heads then nominate individuals, and those individuals are then vetted in a Department of Medicine committee to select the Chair of Medicine Scholars Awards. So our three speakers and our three recipients of the Chair of Medicine Scholars Awards for this year will be first, Dr. Kate Butler from the Division of Nephrology, followed by Dr. Rachel Bender Ignacio from the Division of Allergy and Infectious Diseases, and then followed by Dr. Michael Lenaeus from the Division of General Internal Medicine. If you have questions, please put them in the chat, list them in the chat function. And Elena Crum, the Chief Medical Resident at UWMC, will be compiling those, and then we'll take some of those questions at the end of the three presentations. So I'll turn it over to Dr. Butler now. Kate, take it away. Oh, I'm sorry. Kate is talking today on the role for shared decision-making in the kidney transplant evaluation. So Kate.
All right. Everyone can see the slide okay? All right, great. So first, thanks so much for the opportunity. I really do appreciate it. I don't have any relevant disclosures for this talk. And before I'd start, I'd just like to acknowledge that in this time, it's often difficult to continue work, to talk about research that's not directly in response to the current dominant cultural conversations, and especially around racial justice. And I'm still very much learning about how to think and talk about these issues. So for now, I just want to leave it at an intention to keep learning and do better in my life and work going forward. I'd like to talk with you about our recent work looking at the kidney transplant evaluation process. I'll open with a little bit of background on the kidney transplant process, discuss some of the work that we're doing to better understand the kinds of clinical care that patients receive during the process, and then I'll close with some thoughts for opportunities to improve. So first, I'll just emphasize how valuable a kidney transplant can be for patients with advanced kidney disease. It offers better quality of life and length of life compared with dialysis. And that's really for a broad set of people, people who have multiple comorbidities, people who are older. The problem is that the majority of people will not receive a kidney transplant, and that's for two main reasons. First, the risk of surgery and immunosuppression may be too great for some people. And then second, the supply of deceased donor kidneys from the national supply is really outstripped by the demand, and not everyone has access to a willing and able living donor. Just to give you a sense of the magnitude, in 2016, there were about 500,000 patients on dialysis, and there were only 20,000 transplants that year.
Kate, your microphone is hitting your collar.
Oh.
So there's a lot of background.
Okay, I'll hold it up, thank you.
Okay.
And after all the tests we did.
Yes, it's better now. Yeah, perfect.
Thank you, thank you. So to determine who gets a kidney transplant, candidates have to go through this series of evaluation and selection steps. The approach differs somewhat between institutions, but largely patients have an initial discussion and assessment with their local providers. Their local provider refers them to a transplant center, and then they undergo physical and psychosocial evaluation that's organized by that center. The transplant center committee then selects patients to be added to the national kidney wait list, and they may also at the same time work to identify a living donor. And then finally, patients are selected by the National Kidney Allocation System, or someone finds a living donor and receives a kidney. So there are two broad reasons that I think it's important to study and improve this process. First, our community is increasingly aware of deep disparities in access to kidney transplant that result from the process. Just to give you one example, in 2016, it was estimated that for every 100 years a group of patients spent on dialysis, Black or African-American people received about 2.7 transplants and white people received 3.9. The second reason is that the transplant evaluation itself might have impacts on patient experience and other aspects of care. To put this in context, we know that from the medical community's experience with routine breast and prostate cancer screening that even these kind of benign tests can lead to unanticipated and sometimes profound downstream burdens and harms related to incidental findings, follow-up invasive diagnostics, patient anxiety. And adults with kidney disease receive some of the most complex care of any medical specialty. So you might imagine that engaging in an extensive physical and psychosocial evaluation would be no small undertaking for these people. In our prior work, we found that the transplant evaluation could entail substantial physical and psychosocial burdens, as well as risks for patients, and could have wide-ranging impacts on other aspects of their care. So with an eye to improve both equity and patient care, it's important to understand what's happening during the transplant evaluation process. In part because we have excellent, complete national registries for patients who are waitlisted and who receive a kidney transplant, we actually know quite a bit about outcomes for these groups. And there's also been some excellent qualitative work describing the experience of being on the waitlist and receiving a kidney. There's a lot less known about these earlier steps, and that's in part because there's not really good ways of identifying these groups. They don't show up on national registries. But these earlier steps are prerequisite on the way to getting a transplant, so of course might have an impact on equity and access and patient care. So expanding on our prior work, we hope to take a closer look at the clinical care and processes during the kidney transplant evaluation. We conducted a thematic analysis of patients' electronic medical records. And the purpose of one of these inductive thematic analyses is to describe previously unidentified factors or patterns related to a phenomenon of interest, in this case, the transplant evaluation. And this methodology answers questions like, how does it happen, or what is it like? And of course, I could talk a lot more about qualitative methods, but I'll just briefly describe our approach here. From a national cohort at the VA of patients with advanced kidney disease, we took a random sample of 4,000 patients. And then using a chart review and a chart search tool, we identified the 211 who were referred to a VA transplant center. And that group made up our analytic cohort. Our database includes all clinician notes in the patient's electronic medical record from the time that they enter the cohort through follow-up. And we used a chart search tool to identify and abstract clinician notes that contain the term transplant. And these clinician notes served as the text for our thematic analysis. Then for the analysis itself, we read through text line by line. We assigned codes or descriptions of concepts related to the transplant process to each segment of text. We collapsed those codes into larger thematic categories and identified relationships between those. And then we iteratively developed these thematic categories, frequently returning to the primary text to ensure that concepts were well-grounded until we ultimately developed a final set of interrelated themes. And this analysis resulted in 4 key themes that I'd like to describe in a little bit more detail. And for each, I'll give you a few examples of quotations that came from clinician documentation in the EMR. The first theme described what could be a far-reaching and inflexible medical evaluation for kidney transplant. Clinicians tended to approach the evaluation with this broad mandate to uncover any and all undiagnosed conditions and fully characterize existing diagnoses. And that could lead to a cascade of testing and treatment. The patient said, "I'm like an old car. They keep finding things wrong with me and fixing them." The diagnostics associated with this kind of approach could be invasive and even harmful. In pursuit of renal transplant, he underwent percutaneous liver biopsy, complicated by hemophilia and occult GI bleeding. Even so, there seemed to be little accommodation for patients' unique circumstances and preferences. They recommended CT-guided biopsy, but he initially refused this as he personally feels it's unlikely he has cancer and is willing to assume the risk. He wants a kidney transplant, and this issue needs to be resolved before that. The second theme described a valuation of patient's psychosocial condition. And the psychosocial evaluation could mean quite a deep dive into patients' personal history, including living arrangements, historic substance use, finances, and then the recommendations resulting from these assessments could stray into patients' personal lives. The patient should consider nourishing his relationship with his wife, importance of healthy relationship with wife prior to and during the transplant process. Clinicians' letters of referral to transplant centers that incorporated this kind of information could allude then to patients' moral deservingness for transplant. Because of his youth, combat service, 2 tours in Iraq, and excellent functional status, this writer feels that patients should be given highest priority. As part of the psychosocial assessment, patients were required to identify a support person that could be available 24/7 after transplant. And some patients had family members who were willing to move houses or quit jobs to take on this role. But for others, the substantial ask of family and community could be a real barrier. His wife is disabled, so not able to accompany and help him. It's unlikely he'll be able to find someone who can put their life on hold for a month without any compensation. Next, we described an intense surveillance over patient behaviors in order to determine whether they were compliant with medical recommendations. And how patients fared during the transplant evaluation could be viewed as a kind of test or an indicator of how they were likely to behave after transplant. The entire transplant evaluation is somewhat of a litmus test to see if he can follow through appropriately with each step. And there were extensive efforts to monitor for signs of non-compliance, such as missing dialysis or clinic no-shows. He misses too much dialysis and is well over a year in getting vascular access done to be a good transplant candidate. Compliance red flags. Non-adherence with medications was seen as particularly concerning because of the need to stick to immunosuppressants after transplant, but clinicians also tracked behaviors that didn't seem so directly relevant to post-transplant care. Of note, when he arrived at this VA after checking in, he went to a nearby casino without alerting the floor. He was cautioned about such behavior being perceived as non-compliant. The last theme describes how patients and their local providers seem to have little insight into the evaluations and selection process and could have little power to shape it. Patients were highly motivated to do whatever was asked of them. Appears to be compliant, states that he would do anything to keep from keeping on dialysis. Then to support their patient's candidacy, local clinicians might sometimes do tests they didn't otherwise see as indicated, that they didn't think were best practice, or that they thought might even be harmful. There's good evidence that preoperative revascularization doesn't significantly decrease the risk of perioperative ischemic events. We've become reluctant to perform catheterization solely for this reason. The criteria for listing patient for a renal transplant are different. Some clinicians who are involved in discrete parts of the evaluation seem to be in the dark about how to counsel their patients about the purpose of the test they were doing. Liver biopsy would be indicated as it might change plans in terms of renal transplant. I asked them to talk to their nephrologist about in the event that we find cirrhosis, would that disqualify him for renal transplant, as I was not clear on the answer to this. Documentation from the transplant center could be a little ambiguous about what factors they were using to determine candidacy. And then notes quoting patients' response to these decisions captured how distressed they could be at what they perceived to be an arbitrary or unfair process. I don't understand. I've jumped through hoops and done everything they've asked. He described his hopeless outlook about getting a kidney transplant. Somewhere in Washington, some person behind a desk is going to be looking at my file and say, do we even want to give it to this guy? So collectively, these themes point to barriers to both person-centeredness and equity in the kidney transplant process. Some of the patterns we described, like uncertainty about what to expect from the evaluation, both from the patient and their local providers, rigid top-down decision-making, and limited transparency about why decisions were made, all limit the ability of patients and their local providers to tailor the process to individual needs. Person-centeredness is this increasingly accepted approach to care in which medical processes are oriented around the goals, preferences, and values of individual patients. Of course, the transplant selection process is unique compared with other types of preoperative evaluations in that it formally has to incorporate societal considerations that go beyond individual needs, like fair allocation of limited resources. But I'd say that this isn't a reason that we shouldn't also support individual preferences and values to the greatest extent possible within those constraints. Transplant centers are intentionally given flexibility to tailor their processes to their own populations, to their own center expertise. However, this also allows for heterogeneity and subjectivity in selection criteria and carries the risk of allowing non-evidence-based over-testing, the impact of implicit biases, and even discriminatory practices. For example, there's strict psychosocial selection requirements that we and others have described, but really little evidence base for the relevance of having a dedicated social support person on post-transplant outcomes. And maybe more to the point, these criteria may disproportionately impact people who are already disadvantaged. So these findings reinforce the importance of attention to early steps in the transplant process, and I think specifically suggest a few opportunities to improve both person-centeredness and equity. First, we're in need of more evidence-based selection criteria that have been vetted by the greater community that these centers serve. Local clinicians are in an optimal position to help their patients navigate this process, but to do that, they really need to be informed themselves and have some flexibility to tailor the process to individual needs. So more open communication and collaboration between local clinicians and transplant specialists could improve this approach. And then finally, in parallel with the current initiatives to increase rate of referral and waitlisting for transplant, there should be efforts to support shared decision-making about whether and how patients engage in this process. We need to help patients weigh important risks and benefits in light of what matters most to them. And a last word, I really am hopeful that given the current kidney community's focus on improving access to transplant, as well as our national recognition of equity concerns, that this is really the optimal time to work toward these kinds of changes. So I'm really grateful to Dr. Young and Lyles and the Department of Medicine for their support through the Chair of Medicine Scholars Award and the chance to present in this venue. And I've developed a seriously incredible group of mentors, collaborators, supporters over the last years in the Division of Nephrology, Kidney Research Institute, the VA HSR&D, and Department of Bioethics and Humanities, as well as mentors across the country. And a special thanks to my primary mentor, Ann O'Hare, and my division leadership. Of course, we don't have a lot of time in this session, but I really would love to hear from anyone with thoughts or suggestions. Thank you.
Thank you, Kate. Remember, please, if you have questions or comments, use the chat function, and Dr. Crum will be monitoring the chat function and can address and ask some of those questions at the end of the three speakers' presentations. So thank you, Kate. We'll move on now to our second speaker. Our second speaker is Dr. Rachel Ignacio. Rachel is an assistant professor in the Division of Allergy and Infectious Diseases and also an associate in Vaccine and Infectious Diseases Division at the Fred Hutch. And she's going to talk today about initiating antiretroviral therapy during primary infection. Can we avert long-term sequelae of HIV infection? I turn it over to you, Rachel.
Thank you so much, Conrad and Barbara, and I really appreciate the award and the opportunity to get to speak today. I also really appreciate, Kate, the intention that you set about the difficulty of talking about our usual research during very unusual times. And as someone who is generally an HIV researcher, but currently a COVID researcher, I struggled with what to talk about quite a bit. So I'll give a little flavor of both. I have no disclosures. So the topic that I've been focusing on for the past several years is the person level effects of treating during primary HIV infection. The reason this is very important to study is that since 2016, the WHO had adopted a test and treat approach, which means anybody with a positive HIV status should be treated for that infection and should receive antiretroviral therapy immediately. The evidence that this is really beneficial comes predominantly from two very large randomized controlled international studies called Insight Start and Temprano, which were published in the New England Journal in 2015, and showed that treating people at any CD4 count or any sort of immunologic status had a benefit. And the benefit really is on the outcomes of cardiovascular disease, cancer, and tuberculosis. So these are non-AIDS defining outcomes. But there really is very little data, especially from clinical trials, about whether treating during primary HIV infection, defined as during the first 6 months of infection, has an additional benefit or has another benefit on top of treating early from an immunologic standpoint. As I mentioned, these studies, the Insight Start study and Temprano, looked at people with prevalent infection, meaning were antibody positive and with infection of an unknown duration. We know now also that there are very clear public health benefits of initiating antiretroviral therapy in incident or acute HIV infection. And this was, has really been shown in the reduction of preventing onward transmission, as a significant proportion of people who transmit HIV are not aware of their status and are frequently in the acute or primary period when the viral load is highest, and people are not usually aware of their status. And what really needs to be described better is the long-term individual health benefits of starting antiretroviral therapy during primary infection. And one of the reasons that this is not just a slam dunk is that acute infection is generally defined as infection within 1 month, or when someone is seronegative, meaning only the virus is detected and there hasn't been a detectable antibody response according to some of the traditional tests that are used in clinical practice, which means that very frequent testing and testing using more expensive tests with high intensity in target populations needs to be done to really detect these infections. So during the last 5 years or so, I've been working on a study called SABES, which means do you know, meaning do you know your HIV status? This is a clinical study. The PI of the study is Dr. Ann Doerr, who's pictured in the bottom left in this picture, in collaboration with Drs. Javier Lama and Jorge Sanchez, who are both affiliate UW professors, but at Impacta Peru, which is an NGO in Lima. This is a very complex and phenomenal study that's been really a wealth of information about incident HIV infection and as well as transmission. So this was a study, step one was essentially baseline screening for HIV. People who were negative at that study, that was over 2,000 men who have sex with men and transgender women in Lima, Peru, were followed with monthly testing. That testing included antibody testing, and if negative, went into pooled nucleic acid testing and antigen testing in order to pick up people that had acute HIV. Of those, 216 people with acute or recent HIV infection determined as within 3 months of a last negative test were randomized into the SABES step 3. Which means that they either received antiretroviral therapy on the day of diagnosis or were randomized to defer by 6 months. And at the time that this was done, this was felt to be appropriate because this preceded the WHO's recommendation to treat everybody. And in fact, as the last few participants of the study were enrolled in 2015 and 16 before the WHO had recommended to treat all, but people whose CD4 count met threshold for treatment were treated earlier than their intention by randomization. I should just mention as well, most of our analyses that we're looking at biologic outcomes, we devised a second sort of as treated analysis that looks at how long it was between the estimated date of detectable infection, this is EDDI throughout the rest of my slides, to their date of ART initiation. So that takes into account the fact that many people started in seronegative status, seropositive status, and some people started their ART on time, and other people even started early due to their CD4 count or other factors. So through the rest of these slides, I'll be talking about sort of three groups: people who started antiretroviral therapy within 1 month, within 3 months, or after 3 months from their infection, which was determined by a now published calculator, taking all of their HIV diagnostics into account. So this was recently published in CID, our clinical and immunologic outcomes of the first 48 weeks in this cohort. And what we found, and really has some really very interesting both operational and clinical and immunologic outcomes. So the first thing to note is that of persons randomized to receive immediate antiretroviral therapy, every single one of those 105 participants started ART within 6 days at a median of 1 day. So a very, very thorough ability to get our participants onto antiretroviral therapy immediately. And those who were deferred to receive antiretroviral therapy later, 23% of those actually ended up starting antiretroviral therapy earlier, predominantly for reaching an immunologic threshold, meaning a CD4 count below 350, and 5% actually had symptomatic antiretroviral syndrome, which was a Peruvian criteria for initiating ART, or an opportunistic infection. Another 5% started their ART later than 24 weeks, but still started, and 5% never even started ART. So what we find is really replicating the Temprano and Insight Start studies for people with prevalent infection, which shows that people who are initiated on their therapy the same day as they are given a diagnosis universally start ART, and those who are recommended to wait had a higher chance of not starting or starting late. The other thing that's really interesting and I think is sort of unique because of the ability to have randomization here is that of those deferred to wait only 6 months from their primary infection, 2 developed zoster or shingles, 3 developed oral candidiasis, 1 with oral hairy leukoplakia, and there were 3 cases of TB, including extrapulmonary TB. There were 2 TB cases in the immediate arm, which may in fact have been sort of an iris or immune reconstitution phenomenon. But there were no other opportunistic infections. So this is really sort of new data because we've never had a scenario where we can guarantee that people come to care through routine screening and repeated screening for HIV and not because they're already symptomatic, which is something that many other cohort studies of primary infection sort of struggle to disentangle. For example, the Thai cohort study, because there's no randomization. And many other primary cohorts come to attention because people seek HIV testing because they have a suspicion or symptoms. This is a table just highlighting some of the adverse effects that people experienced. So we essentially categorized all of the symptoms that people experienced as either related to their antiretroviral therapy or not related to their antiretroviral therapy. And what is really notable is that there's a significant reduction in any type of infection or infestation, excluding sexually transmitted infections in those who started, who were randomized to the immediate arm. And then when we look at the intent to, again, the intent to treat group, so by randomization, those with non-related events, meaning any symptom that was not attributed to their antiretroviral therapy, there was a 33% lower chance of having any sort of symptom, and then which was really seen even more strongly in the as treated events. So here we're really seeing that if we just look at any symptom overall and specifically symptoms that are not related to starting on treatment, those who started within 1 month of their infection really experienced the fewest number of events, and that was really dominated by infectious type symptoms. Looking at the immunology here, this is again as treated. We're looking at the blue violins are pre-treatment, and the green violins are after 24 weeks of antiretroviral therapy. And what we can see in this middle group is sort of the natural dip that people experience in their immunologic function during primary HIV, but that those who are initiated on the antiretroviral therapy within a month were more likely to normalize their CD4 count and have a normal ratio at the end of just 6 months of therapy compared to persons who started later, the majority of whom never actually normalized their CD4 count. Normal CD4 ratio is one of the strongest predictors of non-AIDS mortality. So this is really important because in many large cohort studies and over time, we found that having an impaired CD4-CD8 ratio is really predictive of developing cancer, cardiovascular outcomes, many of these aging outcomes, and non-AIDS comorbidities overall. This isn't part of the paper, but we've recently also confirmed in 4 years of follow-up of this cohort that these immunologic changes are persistent throughout all 4 years. So the CD4-CD8 ratio, which really is important, we really can alter that by treating people within 1 month of their estimated date of infection. This is just a little bit more of a holistic view. We took 20 soluble markers of immune activation in plasma, and I don't have them all listed out here, but predominantly kind of interferon dominated and cytokines and chemokines associated with cellular immune responses and responses to viral infections. And this is a principal components analysis, which essentially takes these 20 different biomarkers and reduces them down to 2 dimensions so that it's easy to see them on a graph, and looks at all of that complexity. So this first graph, graph A, is showing what people look like when we found them at randomization. And there are differences, again, because these groups had been infected for different lengths of time when they were randomized at the time of ART initiation. So that's taking into account the randomization. They further start to differentiate. And then I think it's pretty clear to see after just 24 weeks of antiretroviral therapy, there's a nice cluster here of people who are treated within or after 3 months compared to the blue and green dots who are treated within 30 or within 90 days. And when we'd looked at sort of across group and between group comparisons, we really did not see that much difference between the groups treated within 30 days and 90 days, but pretty strong differences between those 2 groups and those that were treated after 3 months since their infection. So the next question that we asked is, does starting antiretroviral therapy during primary infection impact the HIV reservoir? This is, of course, very important both for ongoing immune activation as well as HIV cure strategies. This was a really fun project I got to do with Eva Shelton, who's currently a 3rd-year medical student. This was her III project, and we pulled in Dan Reeves, who is a fantastic mathematical modeler from the Hutch, and we looked at all published studies that had results for total DNA, which is sort of one of the most basic measures of HIV persistence in either bulk PBMC or in CD4 T cells, and sort of adjusted for the differences in sampling and graphed the associations with timing since antiretroviral therapy and the size of the reservoir. So the color of the sphere is how long after ART initiation the sample was taken, and the time on the x-axis is how long between time of estimated date of infection and the start of antiretroviral therapy. If we just zoom in here on those late endpoints, meaning ones that were taken after 1 year of ART, when we know that some of the kind of bumpiness in measurements of HIV persistence have smoothed out, we see this nice, very, very strong correlation between time between antiretroviral therapy and size of the reservoir, meaning the longer one waits to start antiretroviral therapy, the larger one's HIV reservoir is. We looked at this again in our cohort, which the follow-on cohort is called Merlin, which is modulating early events in HIV. And this was done again with Andor and our partners in Peru, and Marta Massanella and Nicolas Chamant, who actually did the HIV reservoir quantitation. These are just some cross-sectional views of what the reservoir looks like at the time of diagnosis via different methods. So this is our standard RNA viral load, just looking in peripheral blood. And one can see that the earlier one is an infection, and these groups are labeled differently in this paper, but early is essentially within 30 days, recent within 90 days, and deferred is after 3 months. Again here, so the same three groups. We see that pretty much all markers of persistence are higher in those within 30 days, which makes sense from what we know about viral kinetics during acute HIV infection. And there's also more sort of suppression or reduction in the reservoir overall, even prior to starting ART in those that are deferred, but more inducibility of that reservoir. Again, this is all off antiretroviral therapy at essentially the visit at which ART was started. Now we're looking at longitudinal declines in the reservoir, and this is a little bit of a busy slide, so just look at the trends, but essentially showing the decay, and it's expressed as a two-phase decay rate, the first very rapid decay, and then the second decay in viral load and total and integrated HIV, as well as 2 LTR circles, which is a form of genomically integrated HIV. And really what we see is that even though people who started antiretroviral therapy had a larger reservoir at the time that they started, they experienced much faster decays in that reservoir. So starting antiretroviral therapy early really impacts the reservoir much more quickly. And we think that we can potentially make bigger gains on limiting the pool of cells that are infected when we start antiretroviral therapy early. These bar charts is just fold change in the sort of the slope. And again, so you can see the largest bars, except for in the 2 LTR circles, are in those that were treated the earliest, showing that we can really make the biggest impact on the HIV reservoir by treating early. And this is just a last sort of small analysis. This is a little bit preliminary, but showing sort of surprisingly an inverse correlation between the total DNA, integrated DNA, and the inducible reservoir at the time of diagnosis. So sort of the more robust immune response, sort of antiviral immune response at the time of diagnosis is correlated with having a smaller reservoir. These are just some of my next steps. So next focus is on HIV acquisition, and all of this data is pending. My last slide is just to talk about what I've been doing in COVID time, which is not HIV at all. And again, that's really, I've been working on clinical trials. So I've been working on 2 clinical trials in our inpatient setting through the ACTG. And we're starting to ramp up one of the active 2 warp speed trials, which I'm on the protocol team for, and will hopefully be opening soon at our center here. And I just want to lastly give a plug for a new COVID clinical research center that's opening at the Hutch in about 2 weeks, and sort of more formal public announcements of that are ongoing, and so stay tuned for more information. And really, I guess this is my last slide, is just to show gratitude for all of the folks that I work with, all of my mentors, of course, the funding from the Chair of Medicine Award, of which I've been very appreciative, and really a lot of collaborations throughout the university, throughout the Hutch, and internationally. So thank you.
All right, thank you, Rachel. So our third speaker and our third Chair of Medicine Scholar recipient is Dr. Michael Lenaeus. Mike is an assistant professor in the Division of General Internal Medicine, and he's going to talk to us today about cryo-EM studies of the cardiac sodium channel. So Mike, take it away.
All right. Thank you very much for the invitation and for the opportunity to present my research. Be a little more basic science. I am going to start talking about the importance of voltage-gated ion channels. First, actually, let me say I have no disclosures before going into my talk. I'm going to start talking about the importance of voltage-gated ion channels. These are a large superfamily of proteins. I'm showing here an evolutionary diagram showing the relationship between different members of this superfamily. Inside of this family, there are the voltage-gated ion channels, like voltage-gated sodium channels and voltage-gated calcium channels that we're going to be talking about today that help conduct electrical signals. There are also ligand-gated channels, like cyclic nucleotide-gated channels. And there are other channels, like trip channels involved with sensation, and of course, potassium channels shown here in red. It's a very large family of proteins that's involved with a number of very important cellular and physiologic processes. They're also extremely important for pharmacology in the process of drug discovery. So I'm showing you a few pie charts on the top here on the right, in part A there, that show the proportion of human protein drug targets in major families. And so this light blue color here are ion channels, indicating that 20% of drug targets are ion channels in humans. And a similar way of looking at that data are to show that the proportion of small molecule drugs that target major families of proteins is also very rich in voltage-gated ion channels here at 18%. So the number of drugs that target this family is one of the highest number of drug classes in humans. It's also maybe neck and neck with those that target GPCRs. On the bottom here, you can see the percentage of drugs that are clinically used in orange and the percentage of drugs that are deposited in chemical databases in blue. Again, showing that the percentage of drugs that are used clinically that target voltage-gated ion channels is very high. And when adding that to those that target ligand-gated ion channels in general constitute a major portion of drug targets. Today's focus is going to be predominantly on the cardiac sodium channel. So here's a cartoon showing the action of this channel and some of its some other related channels in the cardiac cell. So here you see the cardiac cell in blue with the surrounding lipid membrane, and then the ion channels are shown in brown for a sodium channel, and yellow for a calcium channel, and in green for a potassium channel there, with the general direction of ion flow shown in black. So as you all probably remember from medical school, the cardiac action potential, shown there as the black and green line, is started by the influx of sodium through voltage-gated sodium channels. This is extremely rapid and well coordinated. Following that, there is an influx of calcium and potassium during phases 1 and 2 of the cardiac action potential, and then the membrane is repolarized during its final phase by voltage-gated potassium channels. Again, highlighting the importance not only of voltage-gated sodium channels, but the role they play in the generation of the cardiac action potential. They're also, as I had mentioned, the target of many important small molecules and peptides, including those that are clinically used, like local anesthetics and antiarrhythmics. They're shown here on the left in a model of a voltage-gated sodium channel based on a prokaryotic model from years ago. So they're the site of action of these drugs, local anesthetics and antiarrhythmics, but also a number of other drugs that are of interest for future drug discovery, including spider toxins and scorpion toxins, as well as a tetrodotoxin, the pufferfix toxin, and if you like history and Gothic stories, perhaps poisons like wolfsbane and monkshood. In addition to their pharmacology, they're also interesting for physicians because they contain a number of mutations. So specifically in the cardiac sodium channel we're going to be talking about today, NAV1.5, there are a large number of familial arrhythmia mutations, including those that cause Brugada syndrome, long QT syndrome variant 3, and some other familial arrhythmia syndromes. These are shown here in color-coded balls that are placed on the model of the structure of NAV1.5. I don't mean to talk about any of these specifically, only to show you that there's a large number of mutations, mutations in this protein that can lead to arrhythmia. So the big question for me as a structural biologist is trying to get at how is the pharmacology that I just discussed and the mutations that we discussed, how are they translated into the function of the protein and the structure of the protein to lead to their effects? A big stumbling block over the years has been the complexity of the voltage-gated sodium channel, and I'm showing that here in this slide. It's a 24 transmembrane domain protein that folds up into an ion channel. It also has large intracellular loops and extracellular loops, and it has binding partners here shown as the what's called the beta subunit that co-localize with the channel in order to allow it to be functional. So despite the knowledge of this protein and the ability to overexpress it for years and years and years, going back into the 1980s, structural studies have not been successful on it up until the recent past due to its complexity. This leads me into the next part of the talk, specifically focusing on the technique that we're able to use to determine the structure of this protein, which is Cryo-EM. I'm going to start actually by talking about its comparator, which is the older style of looking at structural biology called X-ray crystallography. This was used throughout the 20th century and involves the determination of a structure by generating a diffraction pattern with an X-ray beam through an ordered crystal. The problem with this, if any of you have done this or have experience with this, is that it's quite hard to do. It requires a large amount of protein and crystals, which are extremely difficult for the type of complex proteins that I've been discussing so far, and have proved to be impossible for voltage-gated sodium channels. Over the last 10 to 15 years, there's been the revolutionary development of cryogenic electron microscopy, or Cryo-EM, that has overcome these barriers in structure determination that I just mentioned with X-ray crystallography. In this technique, a very powerful electron beam is directed at a protein sample that's been frozen in vitreous ice, and then micrographs are created, a movie stack of micrographs are created of that protein to allow structure determination. The advantages are that it can be performed with very small amounts of protein, so good when you're working with a large and complex protein like a voltage-gated sodium channel, and a homogeneous sample is not always needed. You also don't need crystals, which can sometimes be hard to grow. So Cryo-EM may be familiar to some of you. It's been used for many years, but when I first learned about this technique in the 1990s and early 2000s, it was only being used to solve very low resolution protein structures. You can see here, though it was discovered in 1968, even as late as the 1990s, it was only being used to study structures at 7.5 angstrom resolution. Here's an example of one of these solved around 2000, in which case the structure of the protein can be inferred, but it's impossible to see the structural details that you'd be interested in when talking about side chain positions or drug binding. So in the last 10, 15 years, the technique has been improved a great deal by a few different things. So I'm showing you a schematic of a general diagram, or a schematic, excuse me, of the sample preparation and data collection for someone doing Cryo-EM. This tube here represents all the hard work that someone has done cloning and overexpressing a protein of interest. Then the experimenter applies that protein of interest to a specialized Holy carbon grid. Here's an example of one here, and plunges that sample into liquid nitrogen cooled liquid ethane, as shown here on the right. When that happens, the water in the sample actually freezes as vitrified water rather than ice. And that process allows the particles of interest to be suspended in that vitrified water, and then to allow micrographs to be determined with the help of a very powerful transmission electron microscope. So this procedure, once the sample is prepared, allows for the generation of micrographs and then class averaging and finally structure determination. The major improvements that have allowed us to actually use this for high resolution structure determination in the last 10 years have been, one, the sample application that I talked about here, and then also the invention of movie detectors rather than single shot photo detectors. I want to talk just a little bit about that before I move on. So in the 1990s and 2000s, in the earliest days of Cryo-EM, detectors captured single images as electrons traveled through the sample and hit the detector. This led to a blurry sample, as the protein samples were generally moving and fluctuating over time, and could only lead to low resolution models. Whereas modern Cryo-EM detectors they're fast enough that they now allow the capture of movie stacks rather than a single image, so that the movie stacks over time can then be compared to each other, motion corrected, and averaged. This process gets rid of the noise that was apparent in the earlier process and allows for higher resolution models. It's been key in the determination of, it's been key in my work and the work of many others. In fact, it's so key that it's allowed the high resolution structure determination of many different proteins from many different classes. This is another arrow showing the determination of structures over time with Cryo-EM. You'll recall in 1968 it was discovered. In 1999 we had only low resolution structures, but now as time has gone by, we are starting to get structures in the 4 angstrom, 3 angstrom, even higher than that range. And for today's talk, it's important to note that around 2013, the first ion channel was determined by a Cryo-EM, the first structure at 3.4 angstroms. And then in 2018, a voltage-gated sodium channel from cockroach was solved with this method, indicating it could be used rather than crystallography for these complicated proteins. I want to show a couple of examples of this technique before we move on to my data. Here are some averages obtained from micrographs from the HERG potassium channel, HERG, which many of you will be familiar with from its role in torsade de pointe arrhythmias. I put these up here just to show the fine detail that we're now able to capture with these electron microscopes, which may be a surprise to some of you who are familiar with only the older technique. But using these 2D averages, one can build a structure of in this case, the HERG potassium channel. In this case, it's colored by its stability, green being higher resolution and more stable, red being more flexible. And then from that, one can build a maybe more familiar structural model showing the electron density map here, and then fit with a protein model that allows, in this case, the determination of the drug binding site for acquired torsade de pointe. that we sometimes worry about in clinical practice. The same method has also been used to determine rabbit calcium channel structures here. Here's an example of the rabbit calcium channel 1.1. I'm not going to go over this in detail due to time constraints, but only to show that this method has been highly successful in determining the structure of voltage-gated ion channels, as well as voltage-gated ion channel drug complexes. For any of those who use nifedipine, diltiazem, or verapamil, this technique has been used to determine the binding site of those compounds in complex with the rabbit channel. So moving on to my experiments now. Working on the shoulders of others and using the technique that was determined with the hERG potassium channel and the calcium voltage gated channel that I was talking about, we return now to our voltage gated sodium channel 1.5. My colleague Dawa Zhang and I worked to determine the best way to overexpress and purify this. Dawa's experiments led to the discovery that truncating the protein and removing the loops on the intracellular and extracellular side led to a stable and highly expressing version of sodium channel. We could then purify it by the use of a flag tag, which is used for affinity chromatography, and then determine the level of expression by using green fluorescent protein. So the way this worked, we would make a different construct that had different loops deleted or different changes to it, then overexpress it in HEK cells, trying to find bright fluorescence indicating a high level of protein. If we found low level fluorescence like that indicated here, we would then move on to a different construct until we found one that had a high level of fluorescence, such as that shown here on the bottom. In that case, we would characterize the channel's function by recording it with electrophysiology, and then fully characterize its activation and inactivation characteristics by determining a GV curve here. These are electrophysiologic techniques I'm not going to discuss in detail. Then we move on to trying to determine the structure in large scale. We grew it in culture by using suspension culture of HEK cells and purified it by size exclusion chromatography shown here. In this case, I just mean to show you that this was a relatively narrow peak, meaning a homogeneous sample, and that when run on an SDS page gel, we have a clean protein sample that includes only the protein of interest and a mild amount of degradation. We're then able to take that sample and to make grids to determine the structure. Shown here, these are the individual micrographs, and the structure of the protein was determined based on the 2D class averages shown here. The 2D class averages are determined by combining a number of micrographs together and then averaging them. Here's an overall structure of the voltage-gated sodium channel 1.5 here. In this case, we were able to build a structural model shown here. The overall resolution of this case was about 3.5 angstroms, and it showed that the voltage-gated sodium channel, as I had mentioned before, is made up of 24 transmembrane domains that fold up into an ion conducting pore, where sodium actually flows through the middle of the channel here, and then the voltage sensitive domains here move in response to voltage. We were also interested in potential drug interactions with this channel. So we tested flecainide, it being the one that has the highest, currently used antiarrhythmic drug that has the highest affinity for this channel. Here's a structural model of flecainide here. So we use the same technique to try to determine the structure in complex with flecainide, starting by determining flecanide's action on our construct. The flecanide's action was roughly comparable to human here, the affinity being 16.6 micromolar for high affinity blockade versus about 1 to 10 in humans. And then we went through the same process to determine the structure. In this case, there was one wrinkle in which I added a protein that binds to the NAV 1.5 channel to allow a complex to be formed, which helps actually form better 2D class averages and improve the quality of the structure. From this sample preparation, we were able to measure micrographs just in the way that I had mentioned before. They're shown here with the individual micrograph on the left, and then the 2D averages shown there. And then create a model. The model here for the channel in complex with flecainide, again shown by resolution with the higher resolution in blue here, showed that flecainide binds in a pocket directly in the middle of the channel and directly occludes ion flow. So it sits below what we call the sodium selectivity filter, where sodium flows through during ion conduction, and physically occludes it by forming an interaction with a hydrophobic portion of the channel and with a polar interaction with the selectivity filter itself. Here's another view of flecanide's binding position. You see it wedges itself between part of the channel and directly under the selectivity filter. And looking at that in an orthogonal view here will show its position. And finally, we made a model looking at other class 1C antiarrhythmics and trying to determine if other class 1C antiarrhythmics might use the same binding pocket for their mechanism of action. This is theoretical, of course, but using that technique, we're able to show that other class 1C antiarrhythmics might use the same binding pocket for their mechanism of action. And although we haven't confirmed this yet, this could be a general mechanism for class 1C antiarrhythmic binding. So in conclusion, the Cryo-EM has revolutionized structural biology. If there are any questions any of you all are asking that have not been able to determine by structure over the years, now might be a good time to reevaluate the use of Cryo-EM in your work. We were able to reveal the structure of the cardiac sodium channel by the use of this, and then also a complex with flecainide. And we think that this is a proof of principle that we can use this system to determine some things about pharmacology going forward. The next steps are already working on propafenone and ranolazine complexes, and also complexes with different states of the channel. Thank you very much, everyone. Here are the folks who work in my lab. I want to especially thank Dawa, who has done all of the major work trying to figure out the best way to overexpress this protein, and Liga, who helps very much with the Cryo-EM. Also received many much support from GIM, listed the folks here, and the K award received from the NIH there on the right. Thank you very much.
Okay, well, thank you. Thank you, all three speakers. Very nice presentations. We have time, I believe, for 2 or 3 questions. Alana, you've been monitoring the chat board. Are there some questions you'd like to pose?
Yeah, there are a couple questions in the chat. The first one was for Dr. Bender Ignacio. The question was, could you please expand on the effect of early treatment, not only on your reservoir size, but also on the composition of the reservoir?
That's a great question, and our collaborator, Nicolas Chamant, who did a lot of this work, is looking at that specifically. There's a lot of thought that potentially some of the longer-lived memory cells that become infected early are the ones that sort of continue to persist. So even though shorter-acting cells, or shorter-lived cells, are cleared more quickly, the reservoir lives in these cells that are, you know, as you could see from the work done, that even within 30 days of infection, the reservoir has really been established there. Although, again, we didn't look specifically at different compartments in this work.
Thank you. We also have another question for Dr. Butler. If you could use AI to get sorting at this complex information within the EMR, if you could comment on that.
That's a good question too. It sounds a bit like what some people are doing with natural language processing. And I mentioned in the chat box, our search tool, some have described as kind of a rudimentary natural language processing tool, but you can get a lot fancier with it. And I think especially as the health systems and clinician notes are all integrated and you can search them across medical systems, there's a lot of potential opportunity there.
Maybe one more question, Alana?
Yeah, so the last question, so for Dr. Lenaeus, could you use this technique to decrease unwanted side effects?
Yeah, thank you for the question. I think that's definitely true. It remains to be seen, but one of the major problems with antiarrhythmics is proarrhythmia, as you all probably recall. And as I just said, the flecainide, using flecainide as an example, it's a relatively low affinity drug for its target, acting only in the micromolar range. It also has very similar affinity to other targets in the heart, potassium channels and other things, so that some of its proarrhythmia probably comes from off-target effects. Now, it's an open question as to whether or not more targeted sodium channel blockers would be a good thing. They may actually cause more arrhythmia. We don't know the answer to that, but certainly we can use this technique to help design more specific sodium channel blockers.
I'd like to congratulate all 3 recipients of the Chair of Medicine Scholars Award for 2020. I'd like to say it's just more than an accolade. Actually, the Department of Medicine awards $100,000 over a 2-year period to each of the recipients for their salary support or for their research support. And so it also does come with funding. And next week, our speaker will be Dr. Matthew Holland, and he'll be giving a combination Department of Medicine, Department of Global Health grand rounds on the unequal burden of climate change on health. So thank you for attending. Thank you, speakers. Congratulations.
Thank you again, everybody.
Thank you.
Thank you.